Okay, so we're going to talk about something new. We're going to talk about the alveolar to arterial oxygen difference. Okay, so I mentioned that in the previous lecture, but didn't really go into a lot of detail. So here are the things. So I want you to define it. I want you to identify the factors and explain how exercise will affect these factors. All right, so the AaDO2 is just the difference in pressure of oxygen between the alveoli and the arteries. Now, in an ideal world, you would have perfect equilibration. Your alveolar pressure would equal your arterial pressure. Life would be great. However, we don't live in a perfect world, and therefore we don't have perfect diffusion. Therefore, we have an AaDO2, and it can be anywhere between 5 and 15 millimeters of mercury. Now, generally speaking, this isn't a big deal, but it can play a role in exercise, and we'll get into that. So when it comes to the AaDO2, there are 4 things that contribute to it or cause it. So we've got something called VQ mismatch, diffusion limitation, and then we've got intrapulmonary and extrapulmonary shunt. So VQ mismatch, if you recall from your physiology class, you've got ventilation and you've got perfusion. So the V is for ventilation. So when we talk about this, especially with VQ matching, we're talking about where we have airflow. Q is for perfusion, you know, the silent Q that no one knows exists. That is where we're talking about blood flow. So if we've got perfusion, we're saying that we have blood flow. So in a perfect world, you want these to be matched. Or in other words, like we've got here, we've got an alveoli that's got air, and we've got blood flow that's going to go pick up that oxygen, get rid of the CO2. Now we can have perfusion, so we have blood flow without ventilation. That's less than ideal because we're just sending blood, but it's not able to undergo gas exchange. And then we've got, in this case, notice that we've got a blockage here. That's what this black circle is. We've got a blockage here, but we have airflow. So there we've got ventilation without perfusion. Now where we have ventilation without perfusion, that's called dead space. Where we've got perfusion without ventilation, that's called shunt. Now the lung is really interesting in that it doesn't all work the same. And what I mean by that is that just things are a little bit different. The pressure gradients are different depending on where you're at in the lung. So we divide it up into 3 zones. So at the top of your lung, the alveolar pressure is greater than arterial pressure, which is greater than venous pressure. Now notice here that the alveolar pressure is so great, it basically pinches off this capillary. Okay, so blood flow can't get through it. So you have lots of air in the top of your lungs, but you don't have a lot of blood flow to pick up the oxygen, get rid of the CO2. Okay. Now, if this actually exists, and there's some debate as to whether or not this zone 1 exists, it goes away, or at least the amount of your lung that stays in zone 1 decreases because of increased blood pressure, which will help force open that capillary. Now, zone 2 is above the heart, but it's not as high up. And in this case, we have no flow because the vein is collapsed due to high pressure in the alveoli. Now, this causes a backup in the arterial side of things. And so what happens is when we have great enough pressure in the arterial side of the capillary, that will force open the vessel. We can undergo gas exchange, and then blood goes into the vein. All right. And then we've got zone 3. This is at the bottom. So here we have high arterial pressure, high venous pressure, and not as high of alveolar pressure. And as a result, we have continuous blood flow. All right. And this is all going to relate to a slinky that I have in class and that we'll talk about in class. Okay. And so when we look at these ratios of VQ, at the top of the lung, we have a high VQ. We have low blood flow, but lots of air. Okay. At zone 2, we have intermittent blood flow, but we have normal airflow. And so we're fairly close to being matched. And then at the bottom of the lung, we have lots of blood flow, but relatively low airflow. And the reason being is that the blood vessels and the gravity are basically forcing those alveoli closed. Okay. Now, I'm not going to ask you to give me the values, but I might ask on the exam, what where do I have a high VQ? At the top of the lung, I'm going to have a low one at the bottom of the lung. All right. Now, when we use the entire lung or take the entire lung in its entirety, I guess that's why you say entire lung, we estimate that VQ is about 0.8. It's important to know these zones aren't even in size, and they can change depending on the blood pressure and ventilation and things like that. Next, we have diffusion limitation. And so we discussed this in the previous video. So diffusion limitation will occur if you have a thick membrane, if you have a low pressure gradient, if you have low surface area, or you have something called reduced transit time. We're going to discuss that later, but basically that's transit time is the amount of time that a red blood cell is in the capillary to pick up oxygen. So if it goes by really fast, there's less time for it to pick up oxygen, get rid of CO2. Next, we have intrapulmonary shunt. So a shunt is where we have blood flow but no airflow. So we've got blood that's not undergoing gas exchange. Okay. Now notice here we've got these down here we've got this blood vessel, pulmonary artery. We've got capillaries in the lung. We pick up oxygen and then it goes to the pulmonary vein. We've got these things called IPAVA. Now they're normally closed, but during exercise they open. We think because they're pressure valves. The problem with getting blood going through them is that it doesn't undergo gas exchange. Okay, and IPAVA stands for intrapulmonary arteriovenous anastomosis. Okay, normally closed, but when we have high pressure in our lungs, specifically exercise and or hypoxia, they open probably as a relief valve, which means we have more blood going through them, which will ultimately reduce the amount of oxygen in our arteries throughout our body. And then finally, we have extrapulmonary shunt. This is the one that's near and dear to my heart, no pun intended, but this is what I studied for 5 years at the University of Oregon. Okay, we have blood flow that'll pass from the right side of the heart to the left side of the heart. We call it a type of extrapulmonary shunt because it's outside of the lungs. The best example is a PFO, or patent foramen ovale, that a third of the population has. Okay, so there's 40 people in our class, so I'd be willing to bet 10 to 15 people have it. Okay, it doesn't seem to cause any problems, but this allows blood to pass from the right side of the heart to the left side. Okay, at rest, maybe 1 to 5% of the cardiac output goes through, but during exercise, when we have higher pressures and higher amount of blood returning to the right side of the heart, we will increase blood through our PFO, if you've got one. I don't, and that will ultimately reduce arterial oxygen in your arteries. So what do you need to be able to do? Define AaDO2, and identify the 4 main contributors to AaDO2 and describe or explain how they affect AaDO2.